Welcome. Today we work through acute cholangitis. This is a biliary emergency, a duct that is blocked and infected at the same time. Here is the idea to hold on to for the whole video. Cholangitis is a closed space infection. Antibiotics matter, but they do not empty a blocked duct. The treatment that changes outcome is drainage. We will follow one patient from the moment he arrives and build the physiology, the Tokyo guideline criteria, the severity grades, and the decision about who needs a drain tonight and who can safely wait. One number will organize all of it. About 80% of these patients settle with antibiotics, and about 20% do not. Let us start at the bedside. Here is our patient. A 68-year-old man comes to the emergency department with 2 days of fever and shaking chills. He has pain under his right ribs, and yesterday his daughter noticed that the whites of his eyes had turned yellow. His temperature is 39.2 degrees Celsius. His heart rate is 116. His blood pressure is 98/56, and he is breathing 22 times a minute. Look at that combination: fever, jaundice, and right upper quadrant pain. You already have a name forming in your head. Hold on to it, but do not stop there, because the vital signs are already telling you this is more than a painful gallbladder. Let us take the history properly. Here is what you should be able to do by the end. Define acute cholangitis and separate it from its neighbors. Explain how obstruction turns into bacteremia. Name the causes of biliary obstruction and their relative weight. Recognize the Charcot Triad and the Reynolds Pentad, and know their limits. Apply the Tokyo guideline diagnostic criteria and the severity grades. Read the laboratories and the ultrasound in a septic, jaundiced patient. Choose between the 3 tests that get argued about. Start the right antibiotic and know how long to give it. And decide who needs urgent decompression tonight. That last objective is the whole point of this video. Everything before it exists to support it. Now the history. It began 2 days ago with a dull ache under his right ribs after dinner. That night he had shaking chills that made the bed rattle. The next day his urine turned the color of tea, and his stools went pale. He has been itching as well. This morning his daughter found him warm, yellow, and slower than usual to answer her. He has had no vomiting and no diarrhea, and no previous episode like this. Notice the pattern. Dark urine and pale stool tell you this is an obstructive picture. Bile is not reaching the gut, it is backing up. And the rigors tell you it is not merely backing up, it is infected. That distinction is the whole diagnosis. The relevant history is short, but it matters. He has type 2 diabetes and high blood pressure. He takes metformin and lisinopril and no anticoagulant. An ultrasound 2 years ago showed gallstones. He never had enough symptoms to justify surgery, so the gallbladder is still in place. He has had no biliary procedures, no stents, and no previous abdominal surgery. He drinks no alcohol and has not traveled. 2 threads to pull here. First, a gallbladder full of stones is a reservoir, and one of those stones can migrate down into the common bile duct. Second, diabetes blunts the inflammatory response. These patients can look better than they are, and then fall off a cliff. On examination, he is warm and flushed. Temperature 39.2, heart rate 116, blood pressure 98/56, respiratory rate 22, oxygen saturation 94% on room air. He is icteric. You can see it in the sclerae and under the tongue. His right upper quadrant is tender, but there is no guarding and no rebound. The Murphy sign is negative. He is oriented, but he answers slowly, and his daughter says that is new. 2 things to notice. The abdomen is not impressive. Cholangitis often is not, and a soft pressure with a fast pulse and a fast respiratory rate is early shock physiology. Do not wait for it to declare itself. So what is cholangitis? The definition is 2 words joined together: obstruction and infection. Bile duct obstruction causes stasis. An infection develops proximal to the obstruction. That word proximal is doing a great deal of work. The infection sits upstream of the blockage, in the part of the tree that cannot empty. That is why this behaves like an abscess, and not like a pneumonia. A pneumonia clears when you sterilize it. A closed infected space does not clear until you open it. Everything else in this video follows from that single sentence. The tests you order, the antibiotic you choose, and above all, how quickly you get the duct open. Let us separate 3 diagnoses that live in the same anatomy. Cholecystitis is a stone stuck in the cystic duct. The gallbladder inflames. The patient hurts. The Murphy sign is positive, but the systemic picture is usually mild. Cholecystolithiasis is a stone in the common bile duct. The patient obstructs and turns yellow and itches, but the bile is not yet infected. Cholangitis is that same obstructed duct, with bacteria growing behind it. The difference between the last two is not the stone. The difference is whether the patient is septic. Jaundice plus pain is a duct problem. Jaundice plus pain plus fever is a duct emergency, and it is managed on a different clock. Why does this topic get a whole video? Because of what it used to do. Before endoscopic drainage existed, acute cholangitis killed more than half the patients who developed it. Today, with early antibiotics and timely drainage, overall mortality sits in the single digits. That improvement did not come from better antibiotics. It came from being able to open the duct. The risk is still not zero. Severe disease with organ failure carries a far higher mortality than the average figure suggests. So the average number is reassuring, and the patient in front of you may not be average. Your job is to work out which of those two populations your patient belongs to. Let us build the physiology. Start with a normal duct. Bile flows downhill into the duodenum, and that flow is itself a defense. It flushes bacteria out mechanically. Bile salts are mildly antibacterial, and the sphincter at the bottom keeps gut contents from climbing up. Now block the duct. Flow stops. The flushing stops. The small numbers of bacteria that reach bile from the gut or from the portal blood are no longer washed away. They sit in warm, stagnant, nutrient-rich fluid, and they multiply without any restraint. You have just created a closed space infection inside the liver, and nothing about that space can drain itself. Now add pressure. The liver keeps making bile, about half a liter to a liter every day, and it has nowhere to go. So pressure inside the biliary tree climbs. Normal pressure is rough light in centimeters of water. Behind an obstruction, it climbs past 20. Here is the critical threshold. Above roughly 20 centimeters of water, the tight junctions between the cells lining the bile ductules give way. The barrier that normally separates bile from blood fails, and that failure is the moment cholangitis stops being a local problem and becomes a systemic one. Notice that the pressure does not need to be extreme. It only needs to cross that line. Watch what happens next. Once the barrier fails, bile under pressure moves the wrong way. Bacteria and endotoxin cross from the bile ductule directly into the hepatic sinusoids and the hepatic veins. That is cholangiovenous reflux. A second route runs into the periductal lymphatics and up the thoracic duct. That is cholangiolymphatic reflux. Follow either arrow, and you land in the same place, the systemic circulation. This is why these patients have positive blood cultures. This is why they rigor, and why they can decompensate within hours rather than days. The duct is now seeding the bloodstream continuously, and the higher the pressure, the faster it seeds. Now the consequence that changes management. An obstructed duct is a place antibiotics struggle to reach. Biliary excretion of most antibiotics depends on bile flow, and there is no bile flow. So drug levels inside the infected bile stay low, no matter how broad your coverage is. Meanwhile, the pressure gradient keeps pushing bacteria out into the blood. You can sterilize the bloodstream faster than you sterilize the duct. The patient looks better, then relapses. The fix is mechanical. Drop the pressure, restore flow, and the antibiotic finally has somewhere to work. Source control beats escalation every time. A second antibiotic is not a substitute for a drain. So what blocks the duct? In about 85% of cases, it is a bile duct stone. That is the answer most of the time, and it is why the endoscopist can usually fix this in one sitting. The remaining cases divide into strictures, either malignant or benign, infection with liver flukes, and recurrent pyogenic cholangitis. Name the stone, then move past it, because the organizing problem is not the stone. It is the obstructed and infected duct. A tumor that blocks the duct produces exactly the same sepsis a stone does, and the same physiology we just built. What differs is how you get the duct open, and what has to happen afterwards. Here are the causes that are not stones. Malignant strictures come from cholangiocarcinoma, pancreatic head cancer, or an ampullary tumor. These often announce themselves as painless jaundice long before any fever. Benign strictures follow biliary surgery, chronic pancreatitis, or primary sclerosing cholangitis. Liver flukes matter in patients from East and Southeast Asia. Clenorchis sinensis and Opistherchus vivarini live in the bile ducts and cause chronic inflammation and stones. Recurrent pyogenic cholangitis produces intrahepatic pigment stones and strictures with repeated attacks. And in the modern hospital, add one more. An old biliary stent that has silently occluded. Who is growing in there? The bile behind a blocked duct is colonized from the gut. Escherichia coli is the most common organism, followed by Klebsiella and Enterobacter. Pseudomonas appears in patients with stents or previous instrumentation. On the gram-positive side, Enterococcus and Streptococcus species, which matter because they change how long you treat. Anaerobes, such as Bacteroides fragilis and Clostridium species, turn up in older patients, in mixed infections, and after biliary surgery. Draw blood cultures before you give antibiotics. They are positive in a large share of these patients, and a named organism is what lets you narrow later with confidence. Now the classic findings. The Charcot Triad is right upper quadrant pain, jaundice, and fever with chills. 3 findings. 1 duct. Pain comes from a distended duct, jaundice from obstructed bile, and fever from the infection sitting behind the block. The triad is present in about 70% of patients with cholangitis. So when you see all 3 together, take it seriously. It is a strong signal, and it should move you straight to imaging and antibiotics. Our patient has all 3 at the door, which is why the diagnosis was obvious in his case. The problem is what happens when the triad is not complete, and we come to that in 2 slides. The Reynolds Pentad adds 2 more findings to the triad: shock and altered mental status, pain, jaundice, fever, low blood pressure, and confusion. It appears in about 15% of patients. Understand what those 2 extra findings actually mean. They are not extra symptoms. They are organ dysfunction. Hypotension is cardiovascular failure. Confusion is neurological failure. A patient with the full Pentad is in septic shock from an infected obstructed duct. That patient does not need a broader antibiotic and does not need another 12 hours of watching. That patient needs the duct opened. The Pentad is not a description. It is a drainage decision. Here is the most important framing in this video. The triad is present in about 70% of patients. Turn that around. Roughly 3 in 10 patients with genuine cholangitis never show you all 3 findings. Older patients, patients with diabetes, and patients on steroids may have no fever or no pain. Sometimes the only finding is new confusion, or a quietly rising alkaline phosphatase in someone who simply seems off. Picture the 82-year-old woman on the ward with none of the classic features. She has it, and she will be diagnosed late. The triad is a rule-in tool. It was never a rule-out tool. Absence proves nothing at all. That is exactly why the Tokyo guidelines built a different diagnostic framework. The 2018 criteria use 3 domains. A is systemic inflammation, fever or shaking chills, or an abnormal white count or C-reactive protein. B is cholestasis, jaundice, or abnormal liver chemistries. C is imaging, biliary dilatation, or evidence of a cause such as a stone, a stricture, or a stent. Now the arithmetic. 1 item from A plus 1 item from either B or C makes a suspected diagnosis. 1 item from A plus 1 from B plus 1 from C makes a definite diagnosis. Notice that you can diagnose this without the full triad, which is the entire point of the framework. What do the laboratories show? You expect a raised white count with a left shift, a raised bilirubin, and a raised alkaline phosphatase. That is the cholestatic pattern. Amylase can rise if the stone is sitting at the ampulla and irritating the pancreatic duct. Transaminases often rise as well, usually more modestly, though an early obstruction can spike them briefly before they fall. Blood cultures may be positive, so draw them first. And add a lactate. In a febrile jaundiced patient, the lactate tells you how much of this is sepsis and how much is simply cholestasis. None of these numbers make the diagnosis alone, but together they build domains A and B. Here are his numbers. White count 18.4 thousand with a left shift. Total bilirubin 6.8, with a direct fraction of 5.1. Alkaline phosphatase 480. Transaminases in the 150s. Lipase normal, so this is not gallstone pancreatitis. Creatinine 1.9, up from a baseline of 1.0. Lactate 3.1. Platelets 122,000. Read this as a whole. A cholestatic pattern with systemic inflammation, plus a kidney starting to fail, and a lactate starting to rise. He already meets the Tokyo criteria for inflammation and cholestasis. Now we need the imaging. Ultrasound is the first test. It is at the bedside. It needs no contrast. And it answers the question that matters most in the first hour. Is the biliary tree dilated? In cholangitis, it usually is. A common bile duct wider than 6 millimeters is abnormal in a patient whose gallbladder is still in place. Ultrasound actually sees the stone itself only about 50 to 80% of the time. The distal duct hides behind bowel gas, so do not let a negative ultrasound talk you out of the diagnosis. A dilated duct in a septic jaundiced patient is enough to act on. The absent stone is a limitation of the test, not evidence that the duct is clear. 3 tests get discussed at this point, and they are not interchangeable. Magnetic resonance cholangiopancreatography. MRCP is non-invasive, needs no sedation, and maps the whole tree beautifully, but it is less reliable for very small stones, and it takes time to arrange. Endoscopic ultrasound is the most sensitive test for small stones, but it needs sedation and an endoscopist. Endoscopic retrograde cholangiopancreatography, ERCP, is the only one of the three that can treat. It finds the stone and removes it in the same session. So in cholangitis, the deciding factor is not diagnostic power. It is therapeutic capability and how sick the patient is right now. So when do you skip the diagnostic imaging and go straight to ERCP? The Endoscopy Society criteria for a high likelihood of a duct stone are a stone visible on imaging, a bilirubin above 4 with a dilated duct, and clinical cholangitis itself. Read that last one again. Cholangitis is on the list. The septic patient has already earned the ERCP. You do not have to prove the stone before you treat the duct. In practice, many centers still obtain magnetic resonance imaging first, even when the likelihood is high, and in a stable patient that is entirely reasonable. But in a patient with organ dysfunction, a scan that delays the drain is the wrong test at the wrong time. His ultrasound comes back. The common bile duct measures 11 millimeters. There is a stone in the distal duct. The gallbladder contains stones, but the wall is not thickened, and there is no pericholecystic fluid. So this is not cholecystitis. Now put the three Tokyo domains together: systemic inflammation, cholestasis, and imaging that shows both dilatation and a cause. That is a definite diagnosis of acute cholangitis. He does not need magnetic resonance imaging. The cause is identified and the treatment is endoscopic. The only remaining question is how fast. And to answer that, we have to grade how sick he is. The Tokyo guidelines grade severity in 3 tiers, and the grade drives the timing of drainage. Grade 3 is severe, cholangitis with dysfunction in at least one organ system. Grade 2 is moderate, no organ failure yet, but any 2 of these: an abnormal white count, a fever of 39 degrees or higher, age 75 or older, a bilirubin of 5 or more, or a low albumin. Grade 1 is mild. It meets neither of the other definitions at presentation. Grade 1 is a watchful diagnosis. Grade 2 is an early drainage diagnosis. And Grade 3 is an emergency. Grade the patient at the door, then grade them again a few hours later. Grade 3 deserves its own slide, because it is defined by a specific list: cardiovascular dysfunction, hypotension that needs a vasopressor, neurological dysfunction, a disturbance of consciousness, respiratory dysfunction, a ratio of arterial oxygen to inspired oxygen below 300, renal dysfunction, oliguria or a creatinine above 2, hepatic dysfunction, an international normalized ratio above 1.5, and hematological dysfunction, a platelet count below 100,000. Any one of these, just one, makes it severe. Notice that 2 of the 6 are simply the Reynolds Pentad, written in guideline language: shock and confusion. Here is the number that organizes this whole topic. About 80% of patients with acute cholangitis respond to antibiotics and supportive care. They defervesce, their pain settles, their bilirubin and white count come down, and their biliary drainage can be done on an elective basis. About 20% do not. Those patients need urgent biliary decompression, usually by ERCP. So your job at the bedside is not really to diagnose cholangitis. You will do that in the first hour with the criteria we just covered. Your job is to work out which of those 2 groups this patient is in, and then to keep rechecking the answer as the night goes on. So who is in the 20%? The patient who is still febrile and still tender after a day of appropriate antibiotics, the patient whose blood pressure does not respond to fluid, the patient who needs a vasopressor, the patient who is confused or drowsy or newly delirious, the patient whose bilirubin or lactate is climbing rather than falling. And any organ dysfunction at all puts them here. In other words, Grade 3 disease is automatically in the 20%, and Grade 2 disease that does not turn around quickly joins it. This is a moving assessment, not a single decision made at admission. Reassess at every set of vital signs. Now back to our patient. On arrival, he had 3 of the Grade 2 criteria: a white count above 12,000, a fever above 39 degrees, and a bilirubin above 5. So he was moderate. Grade 2. 4 hours later, after 2 liters of fluid and a dose of antibiotic, his blood pressure is 78/44. He needs norepinephrine. He is now confused. His lactate has climbed to 4.6. He has just completed the Reynolds Pentad, and he has just become Grade 3. Read that carefully. He did not fail antibiotics because the drug was wrong. He failed because the duct is still shut, and no drug fixes that. What happens in the first hour? Draw blood cultures, then give broad-spectrum antibiotics within that hour. Do not wait for imaging to give the first dose. Give balanced crystalloid, 30 milliliters per kilogram for hypotension, or a lactate of 4 or more. Start a vasopressor if the pressure does not come up. Norepinephrine first line. Keep him nil by mouth. He is going to a procedure. Check the platelet count and the international normalized ratio, and correct them. A sphincterotomy needs a patient who can clot. And here is the step people forget. Call the endoscopist now, not after the antibiotics have had their chance to work. Now the antibiotics. Cover the usual biliary pathogens, gram-negative rods and anaerobes. Reasonable choices: arapipericillin, tazobactam on its own, or a combination regimen, ceftriaxone or ciprofloxacin plus metronidazole. If the illness is severe, use a carbapenem or piperacillin tazobactam. 2 prompts to hold on to. Add enterococcal cover when the patient has a biliary stent, previous instrumentation, or a healthcare-associated infection. And look at recent cultures before you choose. A patient who has been through the biliary tree before often carries a resistant organism from the last admission, and empiric guesswork will miss it. How long do you treat? The Tokyo guidelines answer this in terms of source control. Once the duct is drained and the source is controlled, 4 to 7 days of antibiotics is usually enough. The clock starts at drainage, not at admission. That distinction matters when the drain happens on day 3. There is one important exception. If blood cultures grow a gram-positive coccus such as enterococcus or streptococcus, treat for at least 2 weeks because of the risk of endocarditis. And de-escalate. A blood culture growing a sensitive Escherichia coli is permission to narrow. Broad-spectrum therapy is a starting position, not a destination. Watch the pressure. On the left, the duct is obstructed and sits above 20 centimeters of water. That is the pressure driving bacteria and endotoxin into blood and lymph, and it is why antibiotics alone keep failing. Now follow the procedure. The scope reaches the ampulla and cannulates it. Then the sphincterotomy. The muscular sphincter is cut, and very often pus and bile come out under pressure. That is the therapeutic event. The line falls. Everything after it is clearance. The stone pulled out with a balloon or a basket, and a plastic stent left across the papilla to guarantee drainage while things settle. Put the grades on a clock. Grade 1. Start antibiotics and watch closely. If there is no response within about 24 hours, drain. Otherwise, the drainage can be elective. Grade 2. Do not run a long antibiotic trial. Arrange early endoscopic drainage. Hours, not days. Grade 3. Resuscitate and support the failing organs. Then drain urgently as soon as the patient can tolerate the procedure. Note the order there. You stabilize in order to drain. You do not stabilize instead of draining. The mistake to avoid is treating grade 3 like grade 1. Waiting to see whether antibiotics work in a patient on a vasopressor is how people die of this disease. What if ERCP cannot finish the job? If a sphincterotomy cannot be performed, or the stone is simply too large to extract in that sitting, you can still decompress. Place a biliary stent or a nasobiliary catheter across the obstruction. The stone can be dealt with later once the patient is well. If ERCP itself is unsuccessful or unavailable, the next option is percutaneous transhepatic biliary drainage by interventional radiology, a catheter through the skin and the liver into a dilated duct, where the expertise exists. Endoscopic ultrasound-guided drainage is another route. Surgery is the last resort. Decompression tonight beats clearance next week. ERCP has real risks, and you should consent for them. Post-procedure pancreatitis is the commonest, about 3 to 5% of cases, and higher in younger patients, in women, and after difficult cannulation. Bleeding can follow a sphincterotomy, particularly with coagulopathy or antithrombotic drugs. Perforation is rare but serious, and a partly drained system can stay infected. So if the fever does not settle after the procedure, question whether the drainage is actually adequate. The prevention with the best evidence is a rectal nonsteroidal, 100 milligrams of indomethacin or diclofenac at the time of the procedure. Draining the duct treats the emergency. It does not treat the cause. If the cause was a gallstone and the gallbladder is still in place, that gallbladder is a reservoir which will send another stone. Cholecystectomy should follow, traditionally within 6 weeks, and many centers now do it on the same admission once the patient has recovered. More than 15% of patients left unoperated develop a new indication for surgery. If the cause was a stricture, the path is different. You need tissue, brushings or biopsy at the time of the procedure, and then a definitive plan, a metal stent for palliation, or resection if the lesion is operable and the patient is fit. Now the traps. First, waiting for the full triad before you act. 3 in 10 patients never have it, and the ones who do not are often the sickest. Second, treating a dilated infected duct with antibiotics alone and calling that a plan. Antibiotics buy time. They do not open ducts. Third, letting a negative ultrasound reassure you. The scan misses the distal stone often, and a dilated duct in a septic patient is already enough to act on. Fourth, being reassured when the fever breaks after the first dose. The bacteremia responds before the duct does. A patient can look better for 12 hours and then crash in the middle of the night. 4 more. 5th, anchoring on cholangitis. A negative Murphy sign with jaundice and fever should push you toward the duct, not the gallbladder. 6th, misreading duct size. After a cholecystectomy, the common bile duct is normally wider, so do not call a 9 mm duct obstruction in that patient without other evidence. 7th, forgetting the stent. An old plastic biliary stent occludes silently and presents as sepsis with no pain at all, so ask about previous procedures every time. 8th, the atypical presentation. In an older or a diabetic patient, the only finding may be confusion, or a fall, or unexplained hypotension. Let us close the case. The assessment: a 68-year-old man with definite acute cholangitis by Tokyo criteria. Grade 3, severe, caused by an obstructing stone in the distal common bile duct, complicated by septic shock and acute kidney injury. The plan: resuscitate, piperacillin tazobactam, norepinephrine, and urgent ERCP tonight rather than waiting on the antibiotics. At endoscopy, sphincterotomy, pus under pressure, a 9 mm stone removed, and a plastic stent left in place. He is off the vasopressor by morning. Blood cultures grow Escherichia coli, and he has his gallbladder removed before he goes home. 6 things to carry out of here. 1. Cholangitis is obstruction plus infection in a space that cannot empty. 2. Pressure drives bacteria straight from bile into blood, which is why these patients are bacteremic and decompensate fast. 3. About 85% of the time, the obstruction is a stone. 4. The Triad appears in 70% and the Pentad in 15%, and their absence excludes nothing. 5. The Tokyo criteria make the diagnosis, and the Tokyo grade sets the timing. 6. 80% settle with antibiotics, and 20% need the duct open tonight. Your whole job is knowing which 20% you are looking at. These are the sources behind what we covered: the Tokyo guidelines of 2018 for the diagnostic criteria and the severity grading. The American Society for Gastrointestinal Endoscopy guidance on endoscopy in suspected duct stones. The European Society of Gastrointestinal Endoscopy guidance on preventing post-procedure pancreatitis. The Surviving Sepsis campaign for the resuscitation targets, and the review literature on the pathophysiology of biliary obstruction and infection. Take these to your own reading, and take one sentence to the bedside: an infected duct under pressure does not clear until it is drained. Thanks for working through the case with me.